Thank you very much, Carl Magnus. So that concludes the presentations from all of the committees. What it does do is leave us plenty of time for any questions or comments that you may have on these presentations. Please, if you want to ask a question, just come forward to the microphones in the aisles. And if I can see you still in the light, I will be able to. Please come to the microphone. It would be good if you could say who you are when you ask the question too. Thank you.
Well, thank you very much, Mr. Chairman. It's a pleasure to be here at this symposium. This is my first time I am attending, so I was wondering whether I'm a participant, I am allowed to make a comment or a question because nobody does it.
Of course you're allowed to make a question or
And
comment.
if
Yeah.
I am not, then I can stop.
No, please do.
Okay, my name is Mehdi Sohrabi. I'll just give you a little background. Early in my career, I was health physicist of a research reactor 5 megawatt. At that time, I applied 1 millirem per hour, a sort of constraint for my workers. Instead of 2.5 millirem per hour, I applied 1 millirem per hour, what is called now a dose constraint. Then later I was affiliated with ORNL. I was working there with Professor Carl Ziegler Morgan, one of the ICRP originators and IRPA originator, and then later on a university professor and also in charge of regulatory authority in Iran for over 30 years. And then at IAEA as a regional manager for radiation protection in the Asia and Pacific region. Since that time, I've been always using IAEA standards, ICRP recommendations. I have been teaching, preaching, whatever we have learned and the experiences gained from whatever you have been saying all these years. Now, as being involved in an international committee on high levels of natural radiation and radon areas, which we just recently, in 2040, organized it in Prague, and I had the honor to chair it. I presented an article there as a keynote speaker. It was a different look at ICRP. I'm giving a different view, and I'm saying just a small part of it, and if anybody is interested, I can send the article. I'm looking for feedback. I'm saying this so that you say how good it is. No, I'm looking for feedback. What I'm doing is that working with natural radiation for a long time, I see that a radiation worker, before being a worker, is a member of public. He receives radiation from different sources that a member of public receives. In addition, he gets a little exposure from radiation work. So I have defined radiation worker differently. Now, radiation worker receives this radiation and also from work. Now, we have a range of 1 to 10 millisieverts per year from ONSCAR data, which we are using at the present 2.4 millisievert as a base, for example, for public, which I have a different view. I see we have to use the mean value. So first, we have to apply, this is my comment, we don't have to apply, this is what I'm proposing, to have equal risk of per unit dose of natural radiation and per unit dose from man-made sources. And then we have to consider, you are getting natural exposure chronically all the year long, and we get exposed to occupational exposure fractionally. That means today I get exposed a little bit, tomorrow a little bit, tomorrow, and then we have the weekend, and then we have Christmas time, then we have in some countries a lot of vacations and holidays and so on. So we have fractionation effect in the dose. I'm proposing a model or a hypothesis which we have to consider fractionation effects of occupational exposure. If we use fractionation 1 from natural radiation, we might have a very small fractionation effect from occupational exposure. That means it brings the dose limit, instead of what we are having now, 20 millisievert, it might increase it to 100 millisievert. And then we have to add natural radiation plus occupational exposure, and we have to apply a fractionation correction factor. Especially on epidemiology, there is a lot of data coming up from 1 million US workers, from so many 15 countries, that they are doing it in Europe and so on, and they're all applying only small doses, even from nuclear industry. And for example, the USA, we consider from this NCRP 160, 6.2 millisievert per year, mean dose of public that the worker also receives. And small dose, say 2 millisievert, 1.5 millisievert, the radiation workers receive according to Oscar again. And if we apply the fractionation effect, then we have to correct all our risk factors coming from these epidemiological studies.
Right. Okay. I think that's the longest question I've ever faced, so I'm perhaps going to stop
Thank
you
you
there.
very much. Yes.
And we'll see if we can get some comment. Don Cool, I think I'm going to pass that straight to you.
Just
It's
one more
talking
comment.
about
Just one more comment, may I have?
Okay. Small,
I have published
short.
this. I have published this in May 2015 in Radiation Protection Dosimetry. If anybody is interested, I have hard copy and also electronic copy to provide. Thank you very much.
Thank you. Right. Don Cool, occupation, norm, fractionation. I'm passing that to you to start with.
Thank you very much. Can you,
Yeah.
is this working okay?
Yep.
Okay. So thank you very much. I've actually seen your paper. You raised some very interesting questions because, of course, the system of protection has grown and for various practicality reasons has chosen to address occupational exposure separately from public exposure, separately from medical exposure, and otherwise. And personally, I think you're quite right in the sense that, so I got a photon before I came to work, and I got a photon while I was at work, and I got a photon when I went to the medical clinic on the way home, and I got another photon when I was at home. That's 5 photons, and the cells in my body really didn't know much of the difference. So we need to think carefully about the implications of that. And we also need to think carefully about then what that might do or not do to modify the system of protection. Because you have in one place here, and I'll put this in the experience category, we have some information here, we know some things. We have to look at it from the standpoint of how do we equitably treat different groups of people in different places, what sorts of values, how we respect all of them in their positions, and how we can create a system of protection which is transparent, predictable, and protective. And that is a significant challenge. And personally, looking at applications, I welcome some of these ideas. The extent to which they will work or not work needs to be thought about and considered further, because as I mentioned when I was talking, I came from 33 years of regulation. One of the things that I learned there is that almost everyone is resistive to change, but that if you don't change, you're dead. So we must think about this.
Okay, thank you. John, would you like to make any comment on that?
I don't know whether I've got anything I can usefully add to
okay.
what Don's said, actually.
Yeah, okay, thank you. Any other questions, comments? Please don't be shy. Yes, Renata.
Thank you, Claire. My name is Renate Czerwinski, President of the International Radiation Protection Association. I have short questions, but two.
Okay.
Okay. The first I would like to address to Eliseo Wanyo. Eliseo, and I recognize that the quality assurance in the medical area is still a field which needs a lot of improvements. And maybe my question is more related to an European issue, but it is interesting also for the international community. Did you discuss in your working party the issue of developing criteria for the regulatory notification of significant events in the medical area? This is the first question.
Shall we perhaps address that then? Obviously, we'll let Eliseo address your second
Maybe
question.
he can immediately say no.
Yes. No. Okay. So, Eliseo, please.
Well, I feel this could be one topic of interest more for the health authorities or the regulatory authorities. And now, as you know, there are guidelines what should be the level for notification, but we have never addressed that in the Committee 3 in ICRP, but we can consider that and to look if there is place for advice. But I feel this is more part of the regulatory aspects. One, we have done the recommendations.
Yes, thank you, but it is also an issue for harmonization in that area to inform on significant events in the medical area for lessons learned, more or less. Second question is going to Don. Maybe he knows it already. He has shown us experiences on the third or fourth slide, experiences where we learned a lot. And you mentioned nuclear installations, and you mentioned Chernobyl, and you mentioned Fukushima. Of course, these are very important events, but we had one event at the same time, or in the 80s, 87 or 85, maybe John knows more, John Hunt, the Goiânia accident in Brazil. It was an accident with sources. It is not a nuclear energy or not an accident in the nuclear area. I think we should mention that and consider that also in all our evaluations, because that event didn't lead to such drastic political decisions like the Fukushima accident, for instance, to reject all nuclear energy. So I would like to mention that the consideration of high activity sealed sources and the application is very important. You mentioned it in your last slide. And my question to you is, will you consider the application, for instance, will you consider the safety and security of high radioactive sources in your further work, and will you consider the application of alternative technologies for that sources? and maybe an integrated risk approach.
Okay, thank you. Don?
Yes and maybe. So,
Okay.
so that's the short version. The
Okay.
slightly longer version. Clearly, from the radiation protection framework standpoint, issues associated with the sources, loss of sources, accidents with sources, I mentioned Guyana verbally and others, have driven many things, and we have to very carefully consider what the best mechanisms are for providing radiological protection. Security, a different word from safety in English, but not necessarily other languages, is a key component of that, because if it is not being properly controlled, then the possibility of bad things happening skyrockets, as was the case in Guyana, as was the case in the Republic of Georgia, and the list could go on, certainly. The maybe part is that you're going to have to tell me a bit more about how the framework of protection would dramatically influence the ongoing political debates about which radionuclides or which sources of which form of generation get used in particular applications such as blood irradiators. Because that one is a bit more difficult and much more political.
Okay.
Okay, I think that sort of answers your question, doesn't it? Yeah.
Yes, thank you.
Okay. Yes, please,
Yeah,
Kimberly.
well, I'm going to pick on Don again. but I think Renata brings up a really interesting point that in thinking about the list of experience, I think I'm going to ask us to broaden that and consider medical exposures where we learned a great deal in the last 10 years, and that's in the CT overexposures where there was hair loss in a band, from the CT head for stroke, and all of the campaigns like Image Gently, where I was a co-founder, and we really made a difference in educating all of the medical community worldwide, and realized that we really can overdose our patients, even though we thought we couldn't, and we did. And we learned a great deal from that. So I'd like us to consider adding that to your slide on the right about experience, the hard way of hurting our patients and learning from it, and learning that we do need to have accreditation programs and other programs and guidelines to help all of us do better at what we do. So I'm Kimberly Applegate, I'm Committee 3 and a pediatric radiologist. Thanks.
Don?
Absolutely. As soon as someone can tell me how to decrease the font, have it still pass the folks who want formats such that you can read it, I would welcome adding all sorts of additional examples. But you're quite correct. The slide can always include other things, and we must be careful to look at and bring to bear all of the relevant experiences, as well as all of the relevant biology and all of the relevant thinking about how to best equitably provide protection in order to have a sound, robust system of protection. That's what it's all about.
Correct. And it's true that we have, of course, written on overdose from accidents, and particularly in radiation therapy, but maybe have not recognised as much those from more diagnostic, particularly CT. So yes, I think we know they exist, but it probably hasn't had the same headlines as from other areas. Exactly. Any other questions? Yes, Ted, thank you.
Thank you very much. Ted Lazar from the OECD Nuclear Energy Agency. The first speaker, the questioner, asked about an integrated sort of approach to risk assessment, looking at background, natural background, and occupational exposure together. In emergency exposure situations, there's a similar approach looking at holistically at the protection strategy for the entire circumstance. Is there any consideration at the Commission looking at risk assessment holistically, that is occupational, public, and medical, all at the same time, in terms of what sort of an approach might be used to look at all of those in terms of what's the risk?
Okay, Don, they're all the questions and mainly aimed at your committee, but still.
I wore a red tie on purpose. And I think the answer is yes. I thought you were going a different direction as you started that question, actually. Because one of the things that I think is absolutely essential that we think about are all of the implications associated with doing something. And events at Fukushima and many other events have shown that radiological considerations have to be brought into balance with all sorts of other considerations in terms of impact on the populations. And so I was all ready to say yes, because we have to think holistically about that. But you're right that we also have to think holistically about the individuals who may be involved, who, as our first questioner said, are perhaps members of 3 of those categories, even on the same day. I think it is something that we should look at. And I will now hold up the mirror and say, excellent, give me some ideas.
We'll leave you to have further discussion on that over lunch then. Any other questions? Yes? Is it shorter than the last time?
I promise.
As we head for lunch.
I promise, yes. My question goes to Professor Vano. You mentioned about the protection in radiotherapy. I'm working on photoneutron doses and especially secondary cancer risk. And I've developed a sort of a skin detector which can get a large area and we can get a position-sensitive dose to any point we want inside the beam and outside the beam. What is the ICRP point of view? How much this you consider it important for future research and development? Thank you.
There is no specific figure for that because it depends of the kind of treatment and it depends also what is the circumstances of each of the planning system. Of course, any kind of control and to know this kind of data and what is the doses outside the target beam and what is the profile of the beam is useful in the planning of the treatment. But we cannot say a 10%, a 3%, or a 5%. It depends also of the distance and from the specific treatments. But ICRP has not gone just specifically on that to give this kind of tolerances or data.